Good morning, ladies and gentlemen. My name is Swee Ping Tang, and I'm a pediatric rheumatologist from Malaysia. I would like to thank the Pakistan Society of Rheumatology for inviting me to speak today. Today, I'll be sharing on the European Evidence-Based Recommendations or the SHARE Initiative on Managing Childhood Lupus. We all know that SLE is a severe, chronic, multi-system autoimmune disease of which only 15 to 20% have a childhood onset. Childhood onset SLE shares the same pathogenesis with adult onset SLE, but has a more severe phenotype. There is often higher disease activity with more major organ involvement, especially the kidneys and the brain, and in addition, there is higher disease burden and long-term damage, resulting in significant impact not only on growth, but also the development and psychology of the child. There are now good evidence-based recommendations for adult onset SLE, including this 2019 EULA recommendations, which I'm sure you are all familiar with. Unfortunately, such guidelines are still sorely lacking in children. Let's now look at the European evidence-based recommendations for diagnosis and treatment of childhood onset SLE. Lupus is actually considered a rare disease in Europe with a low prevalence. This in turn makes research fairly challenging, leading to a paucity of evidence-based data and subsequent guidelines for disease management. This often leads to considerable variation in clinical practice, not only amongst different countries or centers, but amongst different clinicians within the same center. This evidence-based recommendation is therefore an attempt to foster equity of access to higher standards of care and uniformity of practice. With regards to the diagnostic recommendations on a general level, firstly, there are currently no validated diagnostic criteria for child SLE, but based on current evidence on the SLIC criteria, which is mainly from adult data, the SLIC criteria can be used as classification criteria in childhood onset SLE. Number two, this SLIC criteria can also be used to help prompt referral to a specialist center to enable timely initiation of appropriate treatment. A referral to a pediatric rheumatologist is warranted even if the child does not fulfill classification criteria for SLE, as this is not a diagnostic criteria. And the suggested criteria for referral includes the presence of ANA positivity with two other criteria, which can be both clinical or one clinical and one immunological. Number three, when considering a diagnosis of SLE, apart from the anti-nuclear antibody, which is the hallmark autoantibody in SLE, the testing of extractable nuclear antigens are also strongly recommended. Number four, however, as there are no antibodies that have specific predictive qualities, for example, disease severity, organ involvement, and the age of onset, so patients who are negative for anti-double-stranded DNA antibodies and ENA can still be diagnosed with childhood onset SLE. Number five, hereditary complement deficiencies can be predisposed to lupus or lupus-like illness. Thus, it is important to consider these complement deficiencies and screen for them in the diagnostic workup, especially in younger children. However, do note that there are also other causes of monogenic lupus outside the complement pathway, thus normal complements does not preclude this possibility. Cardiorespiratory involvement is unusual in childhood onset SLE, but when it occurs, it is usually asymptomatic, especially in the initial period. Therefore, number 6 and 7, early recognition is important, so all childhood onset SLE should be screened with a chest X-ray, ECG, and echocardiogram at diagnosis, and may require intermittent monitoring for future progression of disease or new development of disease. For number 8 and 9, the presence of respiratory symptoms or signs such as exercise intolerance may be a first sign of underlying cardiac or respiratory pathology, although there can be a wide range of differential diagnosis. Hence, in all patients with respiratory symptoms, in the absence of acute infection or who have exercise intolerance, these patients should be worked up for cardiorespiratory cause, including a chest X-ray, a pulmonary function test, including carbon monoxide diffusion, ECG, and echocardiogram. With regards to macrophage activation syndrome, we know that MAS is rare but a severe and potentially life-threatening complication of SLE. These childhood-onset SLE patients can develop MAS at any time of their disease. Therefore, number 10, in all childhood-onset SLE patients, unexplained fever should trigger not only a search for infection, but also for MAS. Both of these conditions share many common features such as cytopenias, fever, and hepatic involvement, but the main difference is in MAS, the ferritin level tends to increase very dramatically, whereas in sepsis, the hyperferritinemia may be modest. For number 11, when MAS is suspected, a bone marrow aspiration should be done looking for possible hemophagocytosis to facilitate the diagnosis of MAS, as well as exclude other causes of cytopenia. However, as MAS can be rapidly progressive and life-threatening, if the child is unstable and a bone marrow aspiration is not possible, then treatment should not be delayed. Let's move on to monitoring and management recommendations of childhood-onset SLE. The frequency of visits to the pediatric outpatient clinic actually is dependent on multiple factors like clinical presentation, severity of disease, as well as the age of onset. Number 1, active disease should be monitored regularly and includes a full clinical evaluation, including body weight, height, and blood pressure. A basic set of investigations should be performed, which includes a complete blood count, serum albumin, creatinine, glomerular filtration rate, C3 and C4, as well as anti-double-stranded DNA antibodies. Number 2, clinical evaluation should be conducted every 2 to 4 weekly for a period of 2 to 4 months after diagnosis or after a flare, and then it can be tapered or adjusted according to the response to treatment. Number 3, all children who are receiving corticosteroids need to be checked regularly for their linear growth. And number 4, also have their disease activity regularly assessed using a standardized disease activity measure like SLEDAI-2K or P-BILAC 2004. In addition to disease activity, number 5, disease damage should also be measured annually using standardized disease damage measures like pediatric slit damage index. For number 6, we know that SLE can affect the eye in many ways, including retinopathy or optic nerve disease. In addition, corticosteroids and hydroxychloroquine, which are commonly used, can also affect the eyes. Thus, all patients with childhood-onset SLE should have access to an ophthalmologist. Number 7, there is actually paucity of evidence regarding the risks of hydroxychloroquine in children. However, annual eye screening should be considered. For number 8, there is actually very minimal published evidence supporting the benefits of sun protection in patients with childhood-onset SLE. But sunscreens are widely recommended to prevent the development of photosensitive rashes and as part of general disease management. Number 9, we need to support the adolescents as they go through a period of transition and prepare them for transfer to adult care once they reach adulthood. In order to have optimal outcome, we need to teach them self-management skills and be responsible for their own health. And as we know, one of the major challenges, however, is non-adherence to treatment. We will now move on to general treatment recommendations for childhood onset SLE. Number 1, there is paucity of data for the use of hydroxychloroquine in children, but adult data suggests that it is not only beneficial, but relatively safe. Thus, hydroxychloroquine is recommended for all children who have childhood onset lupus in the absence of contraindication. Number 2, as I mentioned earlier, non-adherence is a major problem in childhood onset SLE, and this non-adherence is associated with higher disease activity and disease damage. Therefore, in any child where there's a decision to either change or to modify treatment, one must actively check for compliance. Number 3, if disease is severe, such that prednisolone cannot be tapered, although on hydroxychloroquine and the patient is compliant, then an additional DMARD is recommended to improve disease control and permit subsequent steroid sparing. Number 4, mild to moderate hematological involvement. When hemolysis is present and the hemoglobin is lower than normal, then a DMARD should be added to the therapy, but the choice of DMARD has been left open due to the lack of data. And for number 5, if rituximab is required, the doses that are given for childhood onset SLE is similar to that in adults. There are additional recommendations for neuropsychiatric childhood SLE, but in the interest of time, I'm not able to cover that portion, and I will now move on to the management of lupus nephritis. Firstly, proteinuria is not always related to lupus nephritis, and the commonest cause of proteinuria in teenagers is actually orthostatic proteinuria. Therefore, in any case of mild proteinuria, either suspected or actual childhood onset SLE, it is important to exclude orthostatic proteinuria first. And in females, urine samples should not be taken when the patient is menstruating. Number 2, a renal biopsy is indicated if there is suspicion of renal involvement, for example, evidence of renal dysfunction, hypertension, hematuria, especially in the presence of reproducible proteinuria. Number 3, the presence of proteinuria, especially with impaired glomerular filtration rate, should prompt a consult with a pediatric nephrologist to discuss the need for renal biopsy. Number 4, lupus nephritis should be classified using the ISN-RPS or International Society of Nephrology Renal Pathology Society 2003 classification system. Number 5, assessment of renal biopsies can actually be challenging, and as such, a renal pathologist who is experienced in lupus nephritis should be consulted for evaluation of these biopsies. And number 6, even so, misclassification of renal biopsy is still possible. Therefore, if a patient has class 1 or class 2 lupus nephritis and continues to have persistent proteinuria after 3 months, then this is very unusual and would require reassessment of the diagnosis and renal pathology, whether it is a misclassification in the first place or a progression to class 3 or 4. With regards to treatment of lupus nephritis, firstly, the choice of immunosuppressive treatment should be guided by a diagnostic renal biopsy when possible. Number 2, partial renal response as defined as more than 50% reduction in proteinuria to at least subnephrotic levels, and normal or near normal renal function should be achieved by 6 months and no later than 12 months after starting treatment. The long-term aim of treatment, of course, should be complete renal response with early morning urine protein-creatinine ratio of less or equal to 50 milligrams per millimole and near or normal renal function. Number 4, in cases of lupus nephritis with proteinuria, ACE inhibitors or angiotensin receptor blockades should be considered as additional treatment as they have been shown to be antiproteinuric, and the combination use should be guided by a pediatric nephrologist. And number 5, Where renal biopsy is not possible, for example, either the child is critically ill or there's lack of resources to safely perform the procedure, then patients with nephrotic syndrome, hypertension, and impaired renal function should be treated as if they were class 4 lupus nephritis. This is a diagram which actually shows the treatment strategies for the different classes of lupus nephritis, and I will be going through each one of them in more detail. So class 1 lupus nephritis is more common in childhood SLE compared to adult onset SLE, but there are no specific articles on treatment of childhood class 1 lupus nephritis. So based on adult literature and consensus, class 1 lupus nephritis could be treated with low-dose oral prednisolone. And if there are any other organ systems which are involved, apart from class 1 lupus nephritis, then the treatment choice should be guided by these other clinical features. If the child only has class 1 lupus nephritis, then adding other DMARDs is generally not necessary. Class 2 lupus nephritis generally responds well to low-dose corticosteroid therapy, tapering over 3 to 6 months. If proteinuria is persistent after 3 months of all corticosteroid doses cannot be effectively weaned, then one needs to relook at the renal biopsy to see if there has been any misclassification. If there is no misclassification, then adding a DMARD or switching to another DMARD that is effective for lupus nephritis is recommended. Class 3 and Class 4 are termed proliferative lupus nephritis, and these are the most common and severe forms of lupus nephritis in childhood onset SLE. It is commonly present together with Class 5 disease. When present together, Class 3 or 4 with Class 5, then treatment is as per proliferative lupus nephritis, as the proliferative form tends to show a less favorable disease course. There are no randomized controlled trials for treatment of proliferative lupus nephritis in children, unlike in adults, but only several observational cohorts and case series. The first choice of induction therapy should either be MMF or intravenous cyclophosphamide with a combination of corticosteroids. The choice of corticosteroids depends on whether it is severe disease, where one would commonly pulse with IV methylprednisolone, or if it's not severe disease, one can use corticosteroids at a dose of 1 to 2 milligrams per kilogram per day. If they are responding, then the maintenance therapy would be either mycophenolate mofetil or azathioprine. And this maintenance treatment should be administered for at least 3 years. If there's poor response and when poor compliance is suspected, then treatment with IV cyclophosphamide should be started. And if they were previously on cyclophosphamide, you may consider switching to mycophenolate mofetil. And in refractory cases, consider rituximab. For pure class 5 disease, the recommendation is to use MMF in addition with low-dose prednisolone, and the first choice of maintenance therapy would be MMF or azathioprine. Alternative options for either non-responders or those that you do not want to treat with MMF and glucocorticoids will be calcineurin inhibitors like cyclosporine or tacrolimus, intravenous cyclophosphamide, and even rituximab. What about treatment for flares and refractory disease? In general, if a patient is not responding to the prescribed treatment as expected or developing a disease flare, always first check for medication non-compliance. Number 1, for mild flares of class 3, 4, or 5 lupus nephritis, one can restart or increase the dose of prednisolone first and consider a switch of DMARDs. In severe disease, one can consider the use of pulse intravenous methylprednisolone and high doses of prednisolone gradually weaned. Number 3, in those who have refractory disease, again, first check for compliance, optimize the current treatment regime before considering switching to another therapeutic agent. And number 4, in such cases, rituximab can be considered as induction or maintenance treatment in combination with another DMARD. And number 5, calcineurin inhibitors can be considered as a treatment option for lupus nephritis in selected cases, although with consideration of the potential nephrotoxicity after long-term use. So in summary, childhood onset lupus, remember, is not exactly the same as adult onset lupus and often has a more severe phenotype. Clinical research and scientific evidence is scarce in children, and treatment recommendations are largely based on adult practices and limited pediatric data. Always remember that non-adherence to medication is a major concern in childhood SLE, especially amongst the adolescents, and is often the cause of a flare. And management of these children must always be individualized. With that, I thank you for your attention.